I'm taking your title of Design for Good or Evil and thinking about that specifically in the context of digital health technologies, which is the area that I work in mostly now. The pictures down the side here are just examples of some technologies that are used not just by health professionals, but increasingly by us as citizens to help us to manage our own health and our own well-being. And they bring new ways of thinking about design and new issues for designing of technologies, which I think are a great example of designing for good, or perhaps occasionally designing for less good. So what I'm going to talk about today is firstly why I'm talking about digital health. I've already just kind of mentioned that. I'll discuss a few case studies that my team have been working on, particularly looking at how people engage with health technologies when they're managing long-term conditions, whether that's diabetes, chronic kidney disease, mental health issues, a variety of different long-term conditions. And then I'll discuss some visions for the future, the good, the bad, and perhaps the more realistic, which is of course neither entirely good nor entirely bad. So why focus on digital health? Well, health management isn't optional. We all have to engage with health at different times in our lives. And indeed, we should be engaging with our own well-being throughout our lives, staying physically well as far as possible, maintaining fitness, eating well, sleeping well, etc. We can all feel a little bit guilty for not being perfect in all these regards. But none of us is, of course. But it's not only our own health, as I've kind of just illustrated, rather poignantly, it's also the health of our families, the health of our communities. We don't, each of us, sit in an isolated bubble, so we need to work with other people. And increasingly, people are living with and managing chronic health conditions. As the population ages, more and more chronic conditions are becoming of concern. Larger proportions of the population are living with and having to manage these things. And increasingly, technology is being used. And the kinds of technologies that we're working with need to be safe, they need to respect our privacy, they need to be engaging for us to continue to work with them. And of course, they need to be effective. Otherwise, what's the point? But also at the moment, we're living in what are inherently very interesting times, with huge shifts in the way that healthcare is managed and the way that we think about this, both as professionals and as lay people. Historically, worldwide, healthcare has been somewhat paternalistic, with data gathered and controlled by professionals who make recommendations and decisions on our behalf. And that's changing now with a greater emphasis on patient activation, patient empowerment. Patients is all of us at different times. So we've got new models of how data is owned, managed, controlled, shared. And things like tracking devices, whether that's tracking physical activity or tracking health parameters or diet or whatever, these are becoming consumer products that give us as individuals much more control over our own health management and our own health data. And there's also a growing trend towards integrating health and genetics data with lifestyle and environmental data so that we get a richer understanding of how our genes affect our health, how our lifestyles affect our health, how the physical environments affect our health and well-being. And of course, poverty and economics also fit into this picture too. So it's a really exciting time. Also, digital health technologies come in many, many different shapes and sizes, from the kinds of things that I'm showing on the right here. The middle right one is actually, surprisingly, a pretty modern dialysis machine for people with chronic kidney disease. It looks very old, but actually it's pretty much close to state of the art. Technologies that are used by health professionals, and increasingly technologies that we wear, that might be implanted, that we carry with us and use in our everyday lives. So digital health technologies come in many, many shapes and sizes. Today, I'll be focusing more on the ones that we use for ourselves or that family and colleagues might use. So I'm going to synthesize data from 5 studies that my team have conducted. The photograph on this page was taken by one of my students who is studying medication management, and it kind of illustrates the ways that medications aren't formally organized, but are co-located with other things in our environments and not necessarily structured in the way that clinicians might imagine that they are. So the studies I'm going to talk about include one on home hemodialysis, where we interviewed and observed 19 people who are managing chronic kidney disease, and they came from 4 different hospital trusts, all in the UK. A study of diabetes management, where we did interviews and got people to keep diaries, and this involved 40 participants across the UK and North America. The medication management one that I've already mentioned, but for the purposes of this talk, I'm looking at a survey of strategies and how people use apps to help to manage medications, and the survey had over 1,000 respondents. Use of a patient-controlled electronic health record, based around a hospital in the London area, where we interviewed 16 families about their use of the electronic health record. And finally, use of a mindfulness app, where we did pre and post-study interviews with 16 participants who used a particular mindfulness app over a period of over a month, mostly apart from the ones who decided to quit early. But that's another story. So in a lot of these cases, health management isn't optional. People are living their lives and they're finding ways to fit health management and device use into their lives. And this is a burden. It can be an almost constant struggle. So the photo I've included here is a photo that was taken by a participant in one of the diabetes studies, where they took a photo of a barbecue. And the point that they were making was that working out what insulin they need when the timing and the content of their meals is not what they're used to, is not kind of standard, where they're trying to work out the carbs and the other contents of the food and also their activity. It's challenging to manage their blood glucose levels properly in that situation. And where technology isn't designed properly, we find people working around, not adhering according to the way that their clinicians would really like them to adhere. So, for example, in the hemodialysis study, we found one participant reported speeding up the cycle at the start and the end. Hemodialysis takes 4 hours or so and needs to be done every alternate day. So trying to optimize that time, trying to make it take as little time as possible is important to participants. And another participant reported patching up the tubing on his hemodialysis machine because he really needed to dialyze that day because he was feeling so ill, and he couldn't get hold of a technician, so he improvised. And there were many, many other examples of improvisation, some of which have clinicians kind of giving looks of horror because they don't consider them to be safe practices. But they're provoked by the design and by the circumstances. We also had people with diabetes reports admitting that they didn't always carry their blood glucose meter or their insulin with them, for example, when going on a date or when wanting to go out and look smart and not having a big enough bag with them to hold these products. So all sorts of things about the design and about the way they're used affect the ways that people actually work with them. So people manage technology glitches, things like troubleshooting when the technology doesn't work. An example of a quotation from somebody in the diabetes study: "I've never been so glad to be in the pharmacy. The batteries in my meter died this morning right before I taught a class, but I made it through." Somebody on hemodialysis had to improvise with various kind of strange bits of paper and weird things to deal with a kink in the line, to stop the line kinking so that the blood wouldn't flow properly. We're trying to avoid unintentional non-adherence, for example, in medication taking, by studying how people can form habits and how they use external reminders, things in the world, to help them to remember to take their medication. People are trying to live their lives to the full. I've already mentioned insulin pumps not always being used, or glucose meters not always being used. They interfere with sports, they interfere with some other activities, and so people don't use them how they're designed to be used. But also people live with a load of responsibility. So one of the partners who helped in the care of one of our hemodialysis participants said how scared she was that their children would blame her if anything happens to him. It's not just using technology, it's living with the consequences of using technology correctly or possibly getting things wrong, making things unsafe. So we want technology to be easy to use safely, easy to give people a good user experience. But of course, everyone is individual. The photo I've included here is a picture of Carl's veranda. All names have been changed for the purpose of the talk. So Carl has to do dialysis every alternate day, as I've mentioned. He prefers to do it in an environment that is pleasant for him. So he set up his dialysis machine outside, and in the UK, the weather can get quite unpleasant. So he's got all sorts of mechanisms for making sure it stays warm and doesn't get wet. That are all improvisations that make the thing work for him. Of course, people are managing a variety of different kinds of clinical conditions. I've talked about chronic kidney disease, diabetes, hypertension, weight management, stress management, and what is needed for each of those conditions is slightly different. And of course, some people are managing not just one condition, but multiple conditions at the same time. And they often make different kinds of demands on people. So another participant reported not testing her blood sugars on a first date so that she could kind of get to know the person and not have them immediately put off by the fact that she's having to manage her diabetes. Whereas another participant, Diane, tests her blood sugars possibly excessively on a first date to make sure that the potential new partner is actually comfortable with that, can deal with that. In a study of running, we found that different people ran for different purposes and then therefore needed different kinds of technology to make that work properly for them. So, one participant ran for the sheer pleasure of running, didn't really need any technology at all to motivate her to run, to give her the feedback that she needed. But another wanted to improve her performance, so needs technology that measure key aspects of performance, distance, speed, ascent up hills, etc. Whereas another was concerned about his blood pressure and was using running as a way to help him to reduce blood pressure. So that's what he needed to measure, and another wanted to lose weight. So the kinds of measures that people need, the kind of feedback they need, even for something as kind of common, in the UK at least, as running, means that people need different kinds of technologies to support them in maintaining these activities. So what's it mean for technology to work? Well, as I've already noted, Jemima doesn't really need anything. The feedback from her body is enough. Agnes wants performance measures. Brian wants feedback on his cardiovascular health. He needs encouragement to persevere with using the technology. And so on and so on. We can think of different requirements for design based on different people's needs. So everybody has individual attributes. Some people are really keen on numbers. Others perhaps are less so. Some people like to engage with digital technologies. Again, others will do the minimum they can get away with. Are they interested in their health, or do they want to live their lives and pretend that health issues aren't happening to them or to their family members? That's very variable. We don't, the assumption that we all are engaged with our health all the time. Well, actually, if you're overly engaged in your health all the time, it's called hypochondria. It's not considered to be a good thing. So it's about getting a balance. How much do we know about health conditions or understand the kind of physiology or the impacts of medication or practices, things we do on our health? We have different levels of self-efficacy, the sense of being empowered, the sense that we have control over our own health and over the health outcomes, depending on how we behave. We have different coping styles, different lifestyles. And we need to kind of take all of these into account in design and not think that one technology will work for everybody. So one study I'm going to talk about in a little bit more detail is the study I mentioned earlier on engaging with a person-controlled electronic health record. And in particular, the technology that we were studying the use of is a system called Patients Know Best, which has been deployed in quite a few hospitals in the UK and internationally. And in the study, talking to people, interviewing people about how they use the health record and how they engage with their health, we identified 4 groups of participants. I should emphasize this was a fairly small study, and I'd love to have the resources to follow it up and validate it more extensively. But it has an intuitive validity in the sense that we've talked to clinicians about this and they go, yes, that makes sense. So our 4 groups of participants we identified were controllers, people who used the electronic health record extensively, who wanted a lot of autonomy, but actually weren't necessarily very confident in their competence with it, and didn't talk a lot to clinicians about their use of it, wanted to take control, but were reluctant to relinquish control. Clinicians don't like working with people like this, but there are people who this is their way of coping, this is their way of managing health conditions. The second group, which is the textbook patient, are the people who collaborate well with their clinicians. They use the electronic health record appropriately. They're intrinsically motivated to use it and to engage well with their health. They engage well with their clinicians. They turn up at meetings with the clinicians, having looked up test results, having thought about what results might mean, ready to ask questions, ready to discuss changes in the way that they're managing a health condition. They're kind of dream patients. They take control, but they're also prepared to relinquish control when necessary, recognizing the different expertise that they have as families versus the clinical expertise that complements that. The third group is cooperators, people who also try to work well with their clinical team, but rely less on the electronic health record, or take less initiative in working with it, do what they're told, but expect the clinicians to interpret data interpret test results, and so work with clinicians, do what they're told, but don't take the initiative quite so much. And then the final group is the avoiders, the people who don't really want to acknowledge the fact that they are having to deal with a major health condition, don't want to use technology, want to live their lives as if this stuff isn't happening. Therefore, don't engage well with health, don't engage well with the health technology. As I said, this was a very small study, only 16 participants. The majority of those fitted into the middle two categories, the collaborators and cooperators. There were a comparatively small number of controllers or avoiders. It would be great to replicate this study at a larger scale, but it does at least highlight one set of dimensions on which people change. People are different in terms of the ways that they engage with and use an electronic health record, and how it could be designed to accommodate some of these different groups, but also how we mustn't rely too much on everybody engaging with an electronic health record for fear of disadvantaging people who don't have those skills, don't have that facility, don't actually want to engage with these kinds of technologies. So, being more specific about that, the controllers may want detailed access, want it to be mobile, want it to be immediate, don't necessarily engage with the clinicians about it. Collaborators value close communication with their clinicians. They also want their test results immediately. They also want links to other relevant, validated information so that they can make informed decisions in collaboration with their clinical team. Cooperators don't want the results until a clinical consultation. They want to be guided on decisions. They don't need or want the same kind of initiative. And avoiders don't want the technology at all. They need simple, easily accessed information, but also minimal information. Of course, we need to do the complementary study on what clinicians want or need, because both sets of stakeholders really matter in this environment in order to make it possible for them to work together effectively. And the final study I'll just mention briefly is a study of mindfulness, where people were using the app. In this case, the app was one called Headspace, which is widely used, certainly in Europe and North America. I'm not so sure in locally with you. The app was on their phones, so it was portable, but of course, our participants found that not every place was suitable for using it. One or two tried using it on the underground or on a train, and that's not a good place for it, engaging in mindfulness. The app interfered with other phone functions, and so that also was a challenge for people trying to find time for mindfulness using an app. And a lot of participants reported that making time for using it was difficult. So one, for example, said, I'd get into the routine of it for several nights and a few nights, and I would do it every day, and then I would get out of it, and there would be a whole week where I wouldn't have used it. And I'd be like, I want to use it more. So, just continuing use turned out to be really challenging because of social factors, lifestyle factors, and the way that they did fit the app into their lives, or sometimes failed to fit the app into their lives. So, what can we conclude from all this? Well, clearly health technologies need to be fit for purpose. They need to be clinically effective. Otherwise, there's not a lot of point in using them. But they also need to fit with people's lives and practices and values. I hope I've kind of illustrated many ways in which one size doesn't fit all. And so technologies need to be designed for different markets or different audiences. They need to be configurable in some cases, or sometimes you just need different apps. And they need to support appropriate personalization. When technology works, it can be transformative. The people with chronic kidney disease who were dialyzing at home basically were saying, without this, my life would not be worth living. It's really important to do this. It may take a lot of time, it may not be a pleasant procedure, but the alternatives are worse. And the same is true for many of the other kinds of technologies that we studied and worked with. So in terms of thinking about the future, thinking about visions, we might anticipate a future world in which people are appropriately, actively involved in monitoring their vital signs, key health parameters. They're self-managing their health and well-being. We can imagine new styles of analysis yielding additional personal information based on the data that is gathered seamlessly, easily, to help people to manage their lives. As well as accessing personal information, people could also access generic health information and relate that to their own symptoms and experiences so that they actually build a better understanding of their own health and well-being. We could imagine clinicians being involved by being alerted and intervening as needed, because inevitably most of us don't have 5 or 6 years of clinical training. They have an expertise that we need to exploit and also to respect. But in order to be able to intervene, they need to be armed with pertinent and reliable information to make appropriate interventions with us. Drug administration could be remote, patient controlled, so that people don't have to attend hospital so much as they do sometimes at the moment. I have a close friend who's had to go into his local hospital every day for a month now to be administered intravenous antibiotics. It's meant that he hasn't been able to do anything else really for an entire month. In a future case, we can imagine a scenario where that maybe could be done at home equally safely and equally reliably. The future world might also involve individuals' data being quality checked, pseudonymized so that it can't be related back to the individual, aggregated to support population level research so that we actually advance our understanding of health from the current state, which relies pretty much entirely on clinical encounters and clinical measures, to actually take a lot more account of how our health is impacted by other lifestyle factors and other criteria. So that's a great vision. We'd like to think that that's what we're working towards in the future. And indeed, there is huge optimism, huge potential. So this news announcement is taken from a very recent announcement at Great Ormond Street, which is a hospital for children in London, where the Great Ormond Street Digital Research Informatics and Virtual Environments Unit has received a large amount of money from the government, from the National Health Service digital programme, to get it off the ground. The vision is that many new technologies will be deployed in the hospital, will be given to patients who are perhaps under long-term care and just visit the hospital occasionally, will be transforming the patient experience, the ability to gather data, the ability to analyze data in real time, and really kind of transform the patient experience over the coming years. This is the kind of optimism that fits with this really positive vision of the future. Of course, this is a kind of utopian view where we're empowering patients, we're giving them information about their health conditions, about themselves, getting new information from novel sources, transforming the patient experience through our new ways of managing our own health and of clinicians supporting them. The Great Ormond Street initiative is just one example that supports that kind of utopian view. There is, conversely, a dystopian view, a scary, frightening view, where technology is designed without taking account of the social context of use, risking disruptions to traditional relations, whether that's relations between clinicians and patients, or between people and other people within their families, within their communities. Disrupting those relations without necessarily replacing them with a really functional alternative. We might have technology that doesn't fully understand the safety implications of reconfiguring, moving things to different places, perhaps moving things to patients' homes without providing the associated technical and social support that people need. Might challenge traditional views of privacy and data security by making data more accessible by more people, whether through legitimate means or fraudulently, so that people's privacy is compromised in ways that haven't been possible so easily in the past. Prioritizing the interests of one group over those of the primary users, whether that's researchers, insurers, industry, those with the financial interest in having access to people's data. Making people feel inadequate, disempowered, vulnerable, burdened by the new expectations on them in terms of managing health. That's not a good picture. We don't want to go there. And yet the way that health technologies are being developed at the moment, either of these visions is actually possible. Of course, in reality, it's unlikely that it will either be utopian or dystopian. We have a more realistic vision of the future that there are going to be huge advances. There'll be great advances in genomics, in bioinformatics, in sensing technologies, in networking, in miniaturization, in all sorts of new technologies, all sorts of new algorithms, new ways of integrating health technologies into our lives. There's going to be a huge investment in this area. Indeed, there already is a huge investment in this area. But probably the number of winners will be small and the number of losers will be larger. Many organizations will go for the low-hanging fruit, i.e. the technologies that are easy to develop, easier to implement, easier to deploy, that change small bits of healthcare practice without really addressing the complexity of health and healthcare. And I suspect that relatively little attention will be paid to managing the complexity of health and healthcare, or designing technologies that really fit individuals' lives and values. And I think that is the key opportunity and the key area where we as HCI practitioners and researchers have the opportunity to make a difference if we can get our voices heard. So our task, I suggest, is to work with the realities of the situation, the realities of the way that people live their lives, to transform health and well-being. But in order to do that, we need to grapple with some pretty difficult issues. We need to work with people from all walks of life, not just people like me, but people from diverse backgrounds with diverse values, diverse experiences. We need to understand the variability in values and needs and lifestyles and how technology appropriately fits into that, but also where technology is not the right answer. Marrying what is technically possible with what is socially desirable so that we actually achieve the best from both. This involves moving beyond the kind of one-size-fits-all technologies that have commonly been developed. My grandson here is kindly modelling the concept of one size not fitting all. I have to say, at that age, as well as putting on big hats, he would also wear saucepans and waste paper bins, basically anything that would fit over his head. But it's a simple and slightly silly example. Health technologies need to be designed for subpopulations. Obviously, we can't design technologies that are totally unique to each individual, but that they need to be able to be tailored to work for every individual and to work effectively and appropriately for people. Interfaces need to be intuitive, they need to be familiar. Technologies need to be interoperable so that they will work together and not demand too much from people who are trying to use a variety of different kinds of technologies. So to close, the future of health and well-being is in our hands in terms of technology development. And we can choose for good or for evil. There are many research challenges that need shared efforts from technologies, from health sciences, from human sciences, from us as human factors specialists, human computer interaction specialists. Particularly, we can think about this as on World Usability Day, as we're focusing really closely on these kinds of issues. None of us can do it on our own. It is an interdisciplinary journey that we need to take together. And we need to learn from each other and work collectively. I'd like to acknowledge my team. A lot of the work that I've reported on today was funded by the UK Engineering, Physical Sciences and Research Council through a programme called KIMED. And the particular studies that I've talked about were conducted by students and postdoctoral research fellows. James, Aisling, Atish, Hannah, Kathy are the people whose work I've talked about explicitly today, and I'm grateful to all of them. This talk has been made possible by the ACM Distinguished Speakers Programme, and I'd like to acknowledge and thank them. I'd also particularly like to thank and acknowledge Johannes and Freddie for setting all this up, for helping me to plan the visit when I thought I was going to be physically coming to join you in Jakarta, but also in being really flexible when my plans had to change because of my father's health. A little bit more about the ACM. You can read this faster than I can read it out loud, but basically the ACM is a large global community of computing professionals with over 100,000 members in over 170 countries. The ACM helps computing professionals to be their best, to be their most creative. And the vision is about advancing the computing profession and making a positive social impact throughout the world. And I hope that this talk and all the events that you're doing for World Usability Day contribute to that vision and that agenda. So I'd like to close this talk by thanking you. Hopefully I'll be able to join you online if the technology works well. But either way, I hope we can continue the conversation and that you will have a great time for World Usability Day and all the events around it. Thank you so much.